Good morning, colleagues, dear profs. I'm pleased to introduce Alexandra Brüggemann, who is a 2-year resident of ours, and she will give us a short overview of bariatric surgery. Enjoy.
Thank you, Jeanette, for the introduction. So, as you already heard, today we'll be talking about bariatric surgery. What do you feel when you look at these pictures? Do you maybe feel amused or ashamed or even disgusted? So I'm pretty sure these pictures doesn't leave you unaffected if you look at them, and often not in a positive way. And that's actually why obese people often have the feeling that they need to justify their weight. And some say they don't care about the number on the scale, and feel comfortable in their body. But there are plenty reasons why they should care, and that's what I'm talking about today. So some facts about obesity. Obesity has doubled since 1980 worldwide. It is the 5th leading risk factor for premature death. It's causing more death than being underweight, and it's linked to more than 60 other diseases. 1 in 3 11-year-olds is overweight or obese. So some facts about Switzerland. On the left side, you see the percentage of overweight and obesity in men and women in different age groups in 2017. And also to mention, overweight and obesity cost the health system a lot. It nearly tripled within 10 years. So what exactly is obesity and when is it harmful? Obesity and overweight are classified by the BMI, which stands for Body Mass Index, and is a simple index of weight to height. And the WHO defines overweight as a BMI greater than or equal to 25, and obesity as a BMI greater than 30, and differentiates between 3 grades of obesity. In the surgical literature, often other terms as severe or morbid obesity or super obesity are used. On the right side, you see the relation between the BMI and the risk of death. And as you can clearly see, the higher the BMI, the higher the risk of death. So obesity hasn't always been recognized as a disease. Actually, only in 2013, it has been officially recognized as a disease by the Medical Association. Recognizing obesity as a disease helped to improve the way the health system and doctors dealt with this issue, and to improve sensitivity about health condition, which is very important because obesity is a severe disease which can cause death. So just a quick overview about the comorbidities related to obesity. I won't read them all, just to show which systems are affected by obesity. And also to mention, it also affects fertility both in men and women. It's also associated with different sorts of cancer. This slide also gives you a quick impression, particularly breast, endometrial, and colon cancer. And something up to date, obesity is known to be a risk factor for worse disease prognosis in COVID-19 disease. So how about obesity and surgery? Do we need to be restrictive with surgical indication in obese patients? So some facts about obesity and surgery. It's not a risk factor for complications after laparoscopic cholecystectomy, and it's also not a risk factor for readmission after appendectomy, although operations may take a little bit longer. But it is a risk factor for surgical site infections and for more major complications after surgery for gastrointestinal malignancy. So what are our treatment options? Although you're a surgeon and you like to operate, it's important not to start with an operation right away. So first of all, you start with a change of lifestyle, more physical activity, doing more sports. If that doesn't help, you go on to medication. And finally, if that doesn't help as well, then you go on to surgery. So in summary, the treatment option depends on the BMI and the failure of previous therapies. And today we're only talking about the surgical treatment. So which options do we have in bariatric surgery? After a long journey of evolution of different surgical techniques, the most with actually many failures and death, The most common procedures are nowadays the Roux-en-Y gastric bypass, the sleeve gastrectomy, the biliopancreatic diversion, and the one anastomosis gastric bypass. The gastric banding disappeared from the surgical dance floor due to multiple, mainly long-term complications, reduced quality of life for patients, and weight regain. The BPT is an extreme version of surgical surgery, and it's only supposed for revisional trials as other extreme versions. And I'm not going to talk about these techniques today. And the OAGB is not yet proven to be safe on a long outcome, so in Switzerland it's only performed in a trial setting. So I'm not going to talk about it either. How about Switzerland? As you can see, the most common surgical technique is the gastric bypass, followed by sleeve gastrectomy. And if you have a look at other countries and continents, it's a little bit different. The number one bariatric operation is the sleeve gastrectomy, followed by the gastric bypass. So when does it come to surgery and what are the general requirements for surgery? In Switzerland, surgery is covered by healthcare insurance in patients with a BMI greater than 35 and a 2-year history of diet. And since December last year, the BAG included patients with a severe type 2 diabetes mellitus and a BMI between 30 to 35. So I want to speak quickly about the surgical techniques of the standard procedures. First, the gastric bypass. So on the left side, you see the preoperative anatomy, on the right side, postoperative. So what has changed? The stomach has been divided into a smaller upper pouch and a larger lower pouch, and the small intestine has been divided and rearranged approximately 70 centimeters below the lower stomach outlet and has been rearranged into a Y configuration to connect to both. So food is transported by the alimentary channel, and the digestive enzymes and the bile is transported by the biliopancreatic channel, and they both meet in the common channel where absorption occurs. In sleeve gastrectomy, a large portion of the stomach is taken apart from along the greater curve, which leads into a sleeve or tube-like structure. This trial merged data from 2 randomized clinical trials to compare outcomes after gastric bypass and sleeve gastrectomy. 5-year outcomes of the Finnish sleeve pass and the Swiss S-emboss RCTs comparing these 2 surgical techniques were analyzed. Results show that gastric bypass has a better outcome on weight loss, but there was no difference concerning remission of type 2 diabetes mellitus or quality of life at 5 years. Complications were almost equal between the 2 procedures, but there was more reflux noted after sleeve gastrectomy and more internal hernias after gastric bypass. So talking about internal hernias, this paper compared patients undergoing gastric bypass with and without closure of the mesenteric defects. And as you can clearly see, patients where the defects has been closed had a lower probability of reoperations. How about the reflux? This study from Vienna showed a high incidence of Barrett's esophagus and hiatal hernias at more than 10 years after sleeve gastrectomy. So in conclusion, you can say pre-existing large hiatal hernia, GERD and Barrett's esophagus are relative contraindications for sleeve gastrectomy. So how about the results? How about the weight loss? Studies have shown that bariatric surgery has a very successful long-term outcome on weight loss. And as you can see in the graphic, patients undergoing gastric bypass surgery had a better outcome on weight loss. So actually results clearly vote for the surgical treatment. How about diabetes? This study compared gastric bypass and sleeve gastrectomy in patients with type 2 diabetes mellitus. And as you can see, the results show that gastric bypass had a better outcome on remission of type 2 diabetes mellitus. How about surgical treatment versus non-surgical treatment in patients with type 2 diabetes mellitus. This study showed that metabolic surgery had a better outcome on remission of diabetes. And finally, how about cancer? Bariatric surgery is proven to have a protective effect on the development of cancer, as you can see above, particularly the obesity-associated cancer, SI, so like colon and endometrial and breast cancer. So how safe is surgical treatment? This study defined global benchmarks in bariatric surgery to define the best possible outcome regarding gastric bypass and sleeve gastrectomy. So what do we have? We have almost 40,000 elective bariatric surgery cases performed in 19 academic centers on 3 continents. Out of these 40,000 cases, over 4,000 gastric bypass and around 1,500 sleeve gastrectomy low-risk cases have been defined, which means absence of abdominal surgery, diabetes mellitus, sleep apnea, cardiopathy, renal insufficiency, IBD, immunosuppression, anticoagulation, no patients with a BMI over 50 and aged over 65. Patients were mostly female, age around 38 with a BMI around 40. At 90 days, 7.2% of gastric bypass and 6.2% of sleeve gastrectomy patients presented at least one complication, and no patient died. In comparison, mortality in non-benchmark cases was also very low. Most frequent reasons for readmission after 90 days were in both procedures, symptomatic cholelithiasis and abdominal pain of unknown origin. At 90 days, 5.5% of patients showed complications above grade 3A of the Clavien-Dindo classification, and there were 5.5% readmissions. So again, a quick overview about the most frequent reasons for readmission at benchmark patients after surgery. Above, gastric bypass surgery with abdominal pain, symptomatic cholelithiasis, and internal hernia as the most frequent reasons, and below, sleeve gastrectomy with also symptomatic cholelithiasis, abdominal pain, and GERD as most frequent reasons. So, as a summary, obesity is a chronic disease. It's not a lifestyle choice. Surgery is a very effective and a safe treatment. The standard technique in Switzerland, the gastric bypass, and the earlier you start, the better. Thank you much.
Yeah, Alexandre, thank you very much for this brief overview of a relatively complex topic, and I'm very happy that this disease, which is called now, has reached also academic centers, and I'm proud here that we have some not only doing it, but we try to understand better which procedure is best and the effect, and part of local and international study. And for me it's clear, which was not the case 2 decades ago, that it belongs to the academic world too. I have few questions of interest. What's the etiology of obesity? I mean, these people, we see, of course, some continent, our friend with obesity is basically normal, whatever what we see, or the way, and others less, etc. So is that genetic? Is that education? Is that food? Is a combination? Is anything new in the understanding of obesity? Because we heard all the time, don't blame the obese patient, this is in the genes, which is probably not completely true. So I would like to know a little bit about this. Next is the banding. Gastric banding is really dead everywhere. I would like to know, because for a long time ago, some time ago, was some study even done here demonstrating indeed some problems, or long-term problem with the gastric banding. Many of these bands were put, probably many are still in place. So what do we do with patients who have the band? We just wait complication, and is there any indication for the banding? And my third question, we have here also in the lab and others interest in some molecule, for example, that decrease or make the fat in the liver to disappear, like omega-3. Is there any role of omega-3 in maybe not as a single treatment for obesity, but to add when we do this surgery to decrease or control, for example, the steatosis, liver steatosis, or other complication related to fat. So maybe first question, tell us where come the obesity?
Thank you, Alexandra, for your nice talk. Concerning the first question, I think we agree that it's multifactorial, and we are distancing from blaming the obese patients for being obese by themselves. So it's certainly genetic, behavioral as well. Maybe you could say something as well.
Thank you very much. Very nice presentation. It's definitely multifactorial. So if we would be able to stick out one factor, that would really make us famous, I think. What we have to face is that we live in a obesogenic environment. So if it's a mixture of everything. I think those people that were obese 50 years ago are those from today that are severely obese. And what has changed over time is the way how we live. We have a more sedentary lifestyle. Food is everywhere. You can stop on your way from the main station to the hospital. You can stop at least at 50 places to get some snacks or easily available food. We have to look at the way how the food is processed, which is completely different. And that together with education, social status, a more burnout favorable, let's say, working environment, these are all factors that definitely contribute to the fact that people change their eating behavior and get more obese than they were like 50 or 60 years ago. But it's impossible to just name one factor, one gene so far. I think the percentage of people that have a true genetic background of their obesity is below 5% probably. The second question, do we want to just quickly to address the role of gastric banding? That has completely gone. That was an operation that was very fancy, let's say 20, 25 years ago when people really started to get into the business. Now we know it's a very cheap procedure up front when you implant it because it has a very low mortality and very low morbidity, but it's very expensive in the long run because all of these people develop complications, mainly esophageal complications, sort of a pseudo-acalysis because they get all these esophageal dilatations. So that has no role in the standard therapy of obese people anymore. And the third question was
omega-3.
I am afraid no one has really looked at that. There are good data actually showing that weight loss by surgical means is very effective in reducing steatosis up to the level of fibrosis. Once it has reached the level of cirrhosis, it's not reversible anymore, but I think Patou from France has shown some very good data showing that up to this fibrosis stadium by surgical means you can change the fate of the liver and reduce the cause, but the mechanisms are not really known so far.
Thank you for your nice presentation. And I think you have nicely shown that obesity surgery works in terms of the physical results. So less diabetes, less hypertension, better long-term function of the body. I think this is a no-brainer, at least. However, when we are looking at upper GI resection for oncological reasons, we see that quality of life is impaired, and there are also complications because of the surgery itself. And my question relates really to the quality of life, patient-reported outcomes. We also know that there are increased suicidal rates after bariatric surgery as well. So how is quality of life in terms of eating, quality, etc., in those patients?
Thank you very much. That's a very good question. First of all, when quality of life is usually evaluated after bariatric surgery, none of these instruments I know really takes eating behavior into account. So all of these questionnaires don't really ask how well can you eat. So, for example, regurgitation or vomiting is never really asked for. If you want to do that, you have to look at the Jiggly or one of the more traditional questionnaires. But overall, the quality of life has been reported to be significantly better. And I think the difference between your typical patient cohort and ours is, where they come from. for the obese patients, their quality of life is mainly dominated by being physically not able to do a lot of stuff, and they're, that's my impression, that's a personal impression, more willing to accept those restrictions if it comes to eating than those people that come from a more normal life background and suddenly have to face this restrictions in eating. So the obese populations does not seem to regard these limitations in eating as a true reduction in quality of life. They seem to be more willing to accept those for the benefit of being significantly lighter after the surgery. And suicidal rates, that's true. It's not ridiculously high, so it's not, you know, as many critics always try to imply, it's not that half of them really killed themselves after that. It's a very small minority, but it's an important point to look at because it has to do with expectations. So what are we doing here? You know, is this treating a disease? And if it's true that it's a chronic disease, by definition we won't be able to heal it. So all we can do to put it into remission. So even after surgery, if you look slim, you're still sick. You still, you know, we change obese into slim obese, if you wish. But so the treatment, especially the psychological treatment, starts after the surgery. You know, the current standard is that the patients are preoperatively evaluated, and then they are more or less left to their own if they are not going, you know, by themselves to a psychologist. But actually, it should be different because these people need a lifelong partner, medical partner.
When I see these obese patients on the floor, the majority has a CPAP machine. So they have sleep apnea and they have all these things. You know, and we look all mainly on diabetes, and weight reduction is also the study available who looked exactly at the endpoint that sleep apnea might be disappear, that they don't need an assistant anymore in the future.
Yes, these studies exist where people looked at it, and there's a high number of patients that actually get rid of these mechanical support of CPAP at home support, and those that do not get rid of it have at least significant better values and can reduce the support. So there's a scientifically proven effect that this is improved after surgery.
Okay, thank you very much.